Hello, everyone. Just going to give it 1 minute here till noon, and we'll get started talking about thyroid nodules. Okay. Good afternoon, friends. My name is Andy Manos. I'm a PA in interventional radiology, or sometimes called IR, here at North Star Vascular and Interventional in Golden Valley, Minnesota. We're right across from Care 11, 169 and Highway 55. Interventional radiology, what is that? Well, we do image guided procedures. So we use ultrasound machines, x-ray machines to guide us to do procedures. And most of the things we do are surgical alternatives, patients who aren't candidates for surgery or who don't want surgery. And one of my favorite things to do is handle thyroids and thyroid nodules. We have some really cool treatments that have been out for 15, 20 years or so and are gaining traction in the medical community, and there's a lot of people that are interested in it. Number one, half of everyone is going to have a thyroid nodule, so it's very popular. So we're going to get into it, and today we're going to talk about understanding your different options. And really, this is just to educate people on that there are other options, and maybe how to be prepared to have those conversations with primary care physicians, or to know that things can be done if they get certain symptoms. So we're going to jump in. Commonly, someone you notice a lump in your neck. So I've heard many different stories. Hey, my friend told me. My mom said something to me after not seeing me for a while. What's that on your neck? And I didn't even notice it. A lot of times it's incidentally found. I'm clasping a necklace and I noticed that it fits differently, or I could feel the nodule on my neck, or in a Zoom call, I looked and I could see that something was there that didn't used to be. So you noticed a lump in your neck and you get nervous. Like, well, what could that be? And you go and you get checked out and you bring it up. Maybe you're at an annual checkup and you just say, hey, I noticed a lump in my neck. What is that? And your provider is going to just palpate your thyroid and say, oh, yeah, you might have a thyroid nodule. Nodule? Oh, no, what is that? And immediately our brain is telling us bad things. Um, and then we'll get an ultrasound and it'll confirm that it's a thyroid nodule. Okay. What's your brain telling you immediately? Probably before this point, it's already asked this question a million times. Is it cancer? Right? Am I going to die? And the answer is no. It's very unlikely to be cancer. Thyroid nodules are very common. Um, it's unlikely to be cancer. However, on ultrasound, they'll see it, and there is criteria for when a biopsy needs to be done. So a biopsy would prove whether it's cancerous or not, or you might hear it as called a fine needle aspiration. But these things are common in a thyroid nodule workup. Most of the time, though, you're told, well, just wait and watch. You have a thyroid nodule, big deal. Everyone, a lot of people have them. You're okay. A lot of people get told that. It's hard to be told that, right? It's that, well, what is it? Like I can tell, I notice and I see it in the mirror and it bothers me and I don't necessarily want it there. I want to do something about it. Um, and we're going to talk about that. Is it cancer? So no. So 95, really, 90 to 95% of thyroid nodules are benign, meaning they're not cancerous. We'll talk a little bit more about this. A lot of people ask, well, can it transform into cancer? The answer is no. If we ultrasound enough people, we're going to find thyroid nodules in half of adults. So it's a very common thing. A lot of times, this is the number you're told, right? So you might ask at the first visit, and you might say, is it cancer? And they say, no, 95% are not cancers. Don't worry about it. But still, it can be tough. And then maybe you'll move on to the second stage if your nodule was big enough. Usually, size is kind of the first driver of when a biopsy is needed. And you will have a fine needle aspiration. It comes back benign, and you can feel a little bit better about it. But it could be causing symptoms. So, what is a nodule? What does it look like? You can see them, right? You might just have an obvious lump in your neck, but what does it look like to me? Like when I'm looking at an ultrasound, you might just see a lot of grays and whites on this picture, and I just tried to show you with this yellow line here. That's what a nodule looks like. I don't know if you can see my mouse, but there's normal, healthy thyroid tissue around this kind of perfectly oval, a little bit darker circle. That's a thyroid nodule. Very common. This one is mostly solid, might be a tiny bit of fluid in there. Those also could just be blood vessels, and we'll talk about that later. Okay. So you're told all of this. Just wait and watch it. It's fine. You have a thyroid nodule. Don't worry about it. And you're like, well, no, I know it's there and I want it gone, and it might be causing other problems. You might be noticing you can't, and you have to clear your throat a lot, or you might be noticing pressure in your neck. It's pushing on something, trouble swallowing. You might notice that. It might be hard to breathe when you lay down flat. If the nodule is right in the middle of what's called the isthmus, sometimes it's pushing down, and that can be uncomfortable. And so you were told to just wait and watch, but it's starting to affect you, and you don't like it. So you return back to this primary care provider and say, hey, but this is really bothering me. So what can I do? Surgery. If it's bothering you enough, you should have surgery. And it still is the standard of care. To surgically remove a symptomatic benign thyroid nodule. So a nodule that's a bit mass in your neck that's pushing on, causing some symptoms. You can have surgery. Okay, well, what does surgery mean? Surgery means that you're going to have an incision on your neck and they're going to take out either half or all of the thyroid. If they take out half, which would be preferred, of course, because you want to preserve the thyroid gland if possible, there's a 30% chance that the half that's left can't keep up with its function, and you would need to supplement with medicine. So that would mean, there's a 3 in 10 chance you have to take medicine for the rest of your life because you had half of your thyroid removed because there was a thyroid nodule in it. So surgery isn't a small thing, and many people are adverse to surgery for a few different reasons. So sometimes people, well, I don't want surgery. I mean, if the nodule is causing the issues, why should I remove the thyroid? So the nodule is causing the problem. The thyroid is functioning well. You've had some blood tests and it says, hey, the gland itself is regulating my body really well. I don't have hyper or hypothyroidism. Um, it's just the nodule that's causing these symptoms. Why do I need to take out the whole thing? Can't we just leave it? And that's where we come in. So if the problem is the nodule, why remove the whole thyroid? So this is our philosophy for many things, but for thyroids, let's treat the nodule and let's leave the thyroid. You can keep it. There's no medications. There's no scar. Um, Quite a bit of benefits there. So this has changed really over the past decade. It was developed in Korea, and it is becoming very popular around the world, and in America, of course. It allows us to treat the nodule itself. It preserves the thyroid gland, so we don't have to remove the whole organ, and we can just shrink the nodule. We have 2 different treatments that do that. The first one is called thyroid nodule ablation. Sometimes you'll hear it called RFA. RFA describes the energy that's used in the treatment, radio frequency ablation. But this procedure uses a very thin probe. It's placed directly into the nodule, and the probe delivers a controlled heat that treats the cells in the nodule and causes them to shrink over time. Over time, the treated tissue gradually is absorbed by the body and the nodule shrinks. So many nodules shrink significantly over months following treatment, maybe like as up as high as 80%. I've seen a few, I've had a couple patients go 100%, and that's obviously super exciting. It's completely gone, but I really think you're going to find symptom relief even with half the size of the thyroid nodule. And the thyroid gland remains intact, so we can be that precise where we just treat the nodule and not the thyroid tissue around it. Heat shrinks the nodule. This is a picture of me doing this procedure. This is here at our clinic. This is what it looks like if you were over my shoulder. This is an ultrasound machine that I'm looking at to make sure I can put the probe right in the correct place. All these wires on the right has to do with delivering the energy into the nodule. It's just part of it. But the patient, this is much like being at a dentist. You're laying flat, and I'm at just over the head doing in this case here. Another treatment that we do here is called thyroid artery embolization, or what we call TAE. This treatment works in a completely different way. We reduce the blood supply and the nodule shrinks. So oftentimes thyroid nodules grow because they developed an increased blood supply, or those things are related. And during embolization, we place a small catheter through your wrist and we drive up your arm and we find the arteries that go to the thyroid and we release tiny particles that block the blood flow to the thyroid. And without that extra blood supply, the nodule is going to shrink over time. And again, it continues to function well. So on our x-ray machine and with our experience and our technique, we can really just shut down the blood flow to the nodule itself. We also do this procedure for people who have just diffusely enlarged thyroid, which is called a goiter. or a multinodular goiter. And in that case, we would put particles in the entire thyroid. It still shrinks the thyroid and it still preserves plenty of normal gland to resume its function. But again, this procedure, we can shrink either the entire gland or a big nodule, and then the gland itself continues to function normally. So here's a good picture to show TAE. There's a small piece of tubing, which we call a catheter. It goes in at the wrist, and then we drive up to the shoulder and neck, and we find the blood vessel that goes to the thyroid gland, and specifically the thyroid nodule. And we release these little particles that get stuck in the blood flow there, and reduce the blood flow to the nodule, and the nodule shrinks. Again, without surgery, it preserves the gland, no scars. Okay, so both of these treatments are going to give you pretty good results in terms of shrinking the nodule. So it's kind of a wide range, but we'll just say 60 to 90% shrinkage. That amount can happen pretty quickly. We oftentimes are seeing half the size of these nodules at 3 months. It is not overnight. It is a slow process, but I am hearing a lot of people already starting to notice it. I've had a few people tell me the next day or even the same day. I have a great story of someone who told me they could sing an octave higher, which is how they noticed they had a nodule the night of in the shower. She told me, which is a great story. Although I don't know if I want to tell everyone that's what's going to happen. But over time, 60 to 90% shrinkage with both these treatments. And even like I said, if you had half of the treatment, I think I'd be really happy with the result. Because it's pressing less, it's causing less of a problem. You probably won't be able to notice it as well, and it's going to just not be pushing on when you swallow or when you talk or sing. You would notice the visible lump goes away. Okay, so here's a real picture of a patient recently, before and after, for instance. So here's it's a neck mass, an obvious neck mass in the center. Now I didn't show you a picture of this person before this, but that or others, but you can see that the Adam's apple is higher, so it's not the Adam's apple, but there's this lump right here in the neck, and that's actually in the isthmus, or what connects the right and left here in the middle, and it's a nodule. And here's 3 months later, it is visibly and very noticeably smaller. And this was an ablation procedure. And things I don't see on here is I don't see a scar. And this person did great, had a great result. So this is an example, and it can be. This was 70% smaller at 3 months. It's a wide range, but like what I want you to understand is that it's going to shrink. I just don't want you to know. I don't want you to think it's going to shrink immediately. It's going to take a little bit of time, but I think you'll be really happy even after just 1 month. Okay, so our options, those two options, thyroid nodule ablation and thyroid artery embolization. No surgery, no scar, preserve the thyroid. Those are the benefits of the procedure. So in review, most commonly we are doing this treatment for benign nodules. So we've confirmed that they're not cancer with one or oftentimes two biopsies, and that they're causing symptoms. So sometimes I do have to tell patients, hey, I know you have a benign nodule. It's not big enough. It's not causing symptoms, or at least that patient's not telling me it's causing symptoms. And that's not a patient that we should treat. We should probably wait until it grows or starts to cause symptoms, and then we would treat the patient. And just a reminder, the common symptoms would be neck pressure, swallowing discomfort. Cosmetic concerns does play a role. So if it's something you notice and it bothers you, that we have a scoring system for that, and that is a reason to do the procedure. So minimally invasive procedures. This is done here in an outpatient office. You park out front, you come up the elevator, and it's done in the office just right outside my door, and you can go home the same day. So there's no hospitalization. I've had several people with this procedure go back to work the same day. I've had somebody tour a college campus. I have had people who said that they wouldn't be able to do those things. They just said their neck was a little bit sore. A lot of people tell me that when they wake up after the day after the procedure, it feels like they slept on their neck wrong and they kind of have a stiff neck. I've heard that a lot the day after. It's limited to just a couple days, and it can be soreness, and at most something people will take a Tylenol or an ibuprofen for. No scars, back to work the same day. So that's a pretty exciting thing to be able to keep your thyroid, reduce the nodule down, your symptoms go away. You kept your thyroid, there's no scars. It's a pretty slick procedure. So again, for many, there are a lot of thyroid nodules, and most of them, 95%, 90 to 95% are benign or not cancerous. So the goal is no longer to just remove the thyroid like it used to be. The goal is to treat the nodule while you preserve the gland so you can keep your thyroid. The goal of me talking to you about this is I just want you to know that you have options. If you've ever been told you had a thyroid nodule, it's important to know that there are multiple treatment options available today, including observation, right? Do nothing, just watch it. And that's okay sometimes. It really is. And if you need my opinion, I can let you know if that's appropriate. And then you could talk about the minimally invasive procedure I talked about today, which is radiofrequency ablation, thyroid artery embolization, and surgery. I know the thyroid surgeon in town very well. We run patients by each other all the time, and oftentimes surgery is best. So I want you to ask, what are all my options becomes the more important question. Sometimes surgery is the right answer, like I said, but for others, this can be a really good alternative. And I will say that not enough of these primary care providers who are finding these nodules really know that these are the options. Yeah, we're getting the question here. I'm going to answer it. Will I need more than one treatment? So I'm going to, if you could, most of the time, no. It depends on the size. It depends on a lot of different things. Most of the time, one treatment is plenty, and most patients are happy, and they wouldn't have to come back for years, if ever. Occasionally, if it's very big or the location of the nodule, if it is a little bit lower towards the chest or a little bit further back in the neck, sometimes it would require multiple ablations. And for embolization, sometimes we do the procedure twice, where we go through the right wrist into the right neck to shrink the right side. And then you come back 2 weeks later and you go on the left wrist to shrink the left neck, and you do it staged. So depending on the situation, you may have more than one treatment. Most ablations are just one treatment. That's a great question. Okay, so like I said at the top, education is the first step. That's what I hoped I was able to provide here is a little bit of education on some of the other alternatives that are out there. And I think that understanding the condition of the thyroid nodule and all of the options out there is your first step towards making the best decision for your health and for your thyroid health. Okay, what happens next? So you heard this and you found out about these options that you may or may not be excited about, and the next step is to understand your specific situation. So we need to know, what does that mean? Well, review your ultrasound images. Where is the nodule? How big is it? How many do you have? What does it look like? What is the architecture? Is it mostly fluid? Is it mostly solid? All of those things are important. And then your biopsy results. Has it been biopsied? What was the result of the biopsy? Was it biopsied years ago? Should it be biopsied again? Um, and then your symptoms. What symptoms are you having and how much are they bothering you? Yeah, great. Okay, I got another great question here. So we have those three things, ultrasound, biopsy, and your symptoms. From there, we can determine whether observation, just watching it, whether surgery or one of the minimally invasive options we talked about today makes sense. So every thyroid nodule is quite a bit different. Like I just said to that question, and the goal is to match the treatment with the patient. So that takes a little bit of coordination. Sometimes we have to talk to your endocrinologist or to the surgeon about the case and really get the right treatment for the right patient. But again, education is the right step. Understanding your options, like we talked about here, is important. And if you want your case reviewed by me, we're happy to help guide you through that process. You could scan this QR code and set up time with me, and we can go over anything and everything. And if you've never had any of this done, I'm happy to at least begin the process too. That can be done. I was going to leave this for questions, and I have a good question here already. We've already had one. Um, we have someone who says, I have a goiter and it causes me to cough. I've been coughing for 3 months. That's a great question, and that sounds like something that is probably bothersome. So a goiter is a very diffusely enlarged thyroid. Um, the coughing, I would have several other questions. There are a few other things in people's health that can cause a cough. 3 months is a long time. Um, so I would want to ask a couple questions about that, but that could absolutely be because of the goiter, and that's something that we would want to look at. We might need to do a CT scan of your neck, and I don't want to promise the cough would go away, but it very likely would go away within a month after thyroid artery embolization. So TAE is the treatment of choice for the goiter. And I see that you've had a biopsy to find, which is great. Okay, so the surgeon and the endocrinologist if we didn't do enough biopsies or we just started to do these treatments without biopsies, if any of them happened to be that rare risk of cancer, it changes a little bit of the cancer management, which is why we can't do that. So yes, we will ask for a biopsy before any of our procedures that we do. Thank you for that question. Got it. Told several things to set up an appointment with y'all at CAT scan. Okay. How do you choose between RFA and TAE? Wow, that's a great question. Size, really. So we measure these in terms of volume, so length times width times height. And if it's bigger than 30 milliliters, which is 2 tablespoons, if it is bigger than that, it should be done with the arterial embolization. If it's that big, it probably has a robust blood supply and it is going to be safer. It's going to be more effective to do the arterial embolization or TAE. If it is smaller than that, right? So we call it 20 milliliters or most of them, these are less than 10. So most of them are between 2 and 10, which is a teaspoon. RFA is a great choice, depending on location. There are a few that I wouldn't do. Depending, like I said, if it's lower towards the back, there is a nerve that runs by the thyroid, and the surgeons will tell you this too. And if the nodule is smaller and very close to that, I might pass and say, no, that's not a safe one for us to do. So that's how I decide between RFA and TAE. I have a couple other questions. Will this treatment affect my thyroid function or require me to take medication after? No, that's the benefit of our treatments. It will function well. Of course, we still get blood tests before our procedures because we want to prove to your endocrinologist that it wasn't our procedure that changed your function. It's very unlikely that we're going to. So the ablation, if done with a skilled operator who can see exactly what they're ablating under ultrasound and really just ablates the nodule and no normal thyroid tissue, you should not have any damage to that thyroid tissue, so you wouldn't cause hypothyroidism, for instance, in that case. The arterial embolization, especially for a goiter, that's going to be something we have to watch closer because you're embolizing more of the gland. However, a lot of the times people have what's called hyperthyroidism from or Graves' disease from an enlarged thyroid. So if you reduce the thyroid, you actually bring them from hyperthyroid to normal thyroid, and those are the most fun, right? That's a very fulfilling patient to treat. What does the procedure actually feel like? Is it painful? Well, the RFA is rarely painful. I've had a few people tell me that they can feel some radiation of like a soreness, either go back into their throat, up their kind of back of the jaw to the ear, or back into the shoulder. It typically is short-lived and goes away once the procedure is done, but some people have said that it is minimally painful. I'll say over half of our patients are not electing to have sedation. It is very similar to a thyroid biopsy if you've ever had one. Um, because of the heat and the way the nerves are in the neck, sometimes it's difficult to predict which patients will have symptoms and which others won't. But I have seen the full spectrum from someone who didn't even notice we did anything to someone who had quite a bit of pain and took an oral pain medicine before they went home, but they weren't hospitalized for pain management. It wasn't anything that we couldn't handle, and it was managed well over the weekend with some pain medicine. I may have given them a steroid to keep the calm down. How long does it take to recover? This is amazing. It's very fast, right? So for ablation, you're back at your activities same day. It depends what your activity is, depends on what your job is, but I would allow you to go back to work depending on what the requirements of the job were. I will say feeling fully back to normal, I would give it probably 3 full days. So you have the procedure on Friday, for instance, Saturday, Sunday, or you take it a little low, and by Monday, I think you'd be able to return to normal activities. It's very big. And TAE is very similar. We have some restrictions with lifting from the wrist, but from a neck standpoint, you might just feel some soreness. But there really is we're not going to restrict you from anything other than having you watch what you lift with the hand where we went into the bloodstream. Okay. What are the follow-up requirements at your facility? We be traveling quite a distance to do this. Great, great question. So we really care about our patients. We care about our outcomes. So we do have a little bit more of a strict follow-up policy, but it doesn't mean we can't do this over distance. We've done it several times before. So ideally, I would like to see you at 1 month, 3 months, 6 months, 12 months, and 24 months. That's the full schedule. I don't really need to see you, I would, if you could get an ultrasound done in your home at your near your house, and we could do a virtual visit to check in. I could review the ultrasound, compare it to your prior ultrasound, and we could talk to check in how your symptoms were doing. That is totally acceptable, and we do that routinely. We do get into some legal things with, well, if you're going to do a telehealth visit, the other person must be on Minnesota soil. So oftentimes we're telling our patients, well, you got to at least come across the river into Moorhead for the visit if you live in Fargo, for instance. Or if you're a lot of people in the five-state area will travel to Minnesota for some reason, even if it's not the Twin Cities. Or we can review sometimes what we like to do is we'll review the full chart and I'll be able to see your ultrasound and your biopsy results and review some notes from a primary care provider or an endocrinologist. And then you can come the day before and I can have the consultation and then the procedure scheduled the next day. And it's just like, well, you're already a candidate and we just go right into it. We've done that too, and that works really well. I hope that answers your question. Thank you for that. Um, I've already been told I need surgery. Can I be a candidate for this instead? Yes, absolutely. So I've had that happen several times before. Sometimes I've been too late where they just went for the surgery, and that's okay. At least their nodule was gone and their symptoms improved. Yes, you can absolutely be a candidate for this. So if you were having a surgery to remove the thyroid nodule that was causing the symptoms, one of our treatments is likely going to be right for you. There might be some discussion, and ideally, I'd be able to speak with the surgeon. But yes, so you can still be a candidate for this procedure and likely would be. For someone who's just been told to watch their nodule, at what point should they consider treatment instead? Great question. When it bothers you enough, when you feel like it's limiting you, where it's occupying your mind more, like I don't know, daily instead of weekly, it's daily, or you're noticing it every time you swallow, or you're in the church choir and you really want to sing and you're starting to sing differently and you think your voice is affected from your thyroid nodule. When it's starting to affect your life like that, I think it's time to consider something. And whether that's minimally invasive treatments like ablation or embolization or surgery, it's probably a good time for that. How do you find out if you qualify? Well, that QR code back here, I can show it again. Is a good place to start, or you can look us up North Star Vascular Interventional, and we have a phone number. You can text us, you can call us, you can email us, you can chat on our website or so anything, and we can arrange for that evaluation. How much will my nodule shrink? Well, 69%. How long does that take? Depends on the situation, depends on how big it was. But for the most part, I like to tell people 50% at 3 months, 75% at 1 year. We've been having better results than that, but that's what the research papers say is the volume reduction from our treatments is about 75 to 80%. Can I shrink a thyroid nodule by myself without one of these treatments? That's a great question. I hear that one a lot. So that the answer is maybe, maybe not. The research that I have consumed doesn't really support that you will be successful shrinking the nodule without a treatment. There are a few things you can do. So a lot of people ask about supplements they can take or what can they do. And I will say that your overall health is important, so we can start there. But specifically to thyroid, is you want to make sure you're getting enough iodine. Okay, so people here who live in the Midwest um, don't have access to as much seafood, right? So it's actually known that the Midwest has more thyroid issues and thyroid nodules because they're iodine deficient. Now, good places to find iodine would be fresh fish. Actually, iodized salt will have some in it, but so pay attention to that. But you can't take too much either, so you have to have that being monitored. Or be a little bit mindful about how much you could take. And selenium is another one. And those two are what are usually my answer to this question. There are some other things out there that I may not recommend. And you can try it and we can watch and wait and you can see if you slow down the growth of it. But I would say more times than not, it's probably just going to grow on its own, regardless of what you do. But again, sleep, exercise, diet, all of those things should be able to help the thyroid function because the thyroid's involved in a lot of things. Oh, I got someone excited. They said they have all this stuff done and their appointments later in the month and they want to be done sooner. Yes, I can. I'll pull some strings for you since you were here and you're so interactive and I appreciate it so much. Let me just make a note to have my team follow up with you for that. Okay. Um, That's what I had planned for you guys today. I very much appreciate your time. I very much appreciate your engagement. These were fabulous questions. And I would look forward to meeting you. If you have any questions about how our minimally invasive treatments could potentially help you. Um, I hope you guys have a great day. Thanks for your time.